Good afternoon and evening, everyone, and a very warm welcome to our webinar on IVF treatment with donor eggs, hosted by the London Egg Bank. My name is Shifa, and I work as a patient care coordinator here at London Egg Bank. And we're very pleased to have you with us here today. Thank you so much for joining us. Tonight's session is designed to give you a clear and compassionate guidance on IVF with donor eggs, whether you're just beginning your journey or are exploring donor egg treatment as an option. We hope today's session give you the clarity, confidence, and support that you need. I'm delighted to introduce to our speaker for this evening, Dr. Michael Summer, a highly experienced fertility specialist who has worked with countless individuals and couples over the years to help them achieve their dreams of parenthood. Dr. Summers will walk us through the donor egg IVF process, what to expect, how we match recipients with donors, and latest success rates and clinical advancements in the field. And after Dr. Sama's presentation, we'll open the floor for question and answer session. Please feel free to submit your questions at any time using the Q&A box below, whether they are medical, emotional, or logistical. There is no question that is too small, and we will do our best to answer as many as we can before we wrap up. So without further ado, please join me in welcoming Dr. Summers.
Thank you, Shifa, for the introduction, and welcome to all of you who have very kindly taken the time to attend this seminar that's designed to give a brief overview of the services that are provided through the London Egg Bank and the use of donor eggs. Donor egg as a form of fertility treatment has a long and interesting history. It has its origins back in the 1990s, in the early days of even not long after IVF was first described. But the technologies have changed dramatically, certainly over the last 15 years or so. And now we are able to not only offer donor egg treatment through the use of synchronized cycles with fresh egg donation, but we also have access now to vitrified or cryopreserved donor eggs as part of the London Egg Bank. So individuals and couples nowadays have far greater options in terms of fertility treatment than they did 10 years ago. So the London Egg Bank has a long history in providing the services of egg donation. The actual services started some 30 years ago with egg donation using fresh egg donors. And in the last 10 or 12 years, it's been really the growth of the London Egg Bank, as I've mentioned, as a result of advances in technology, particularly the methods that are used to vitrify human eggs, which up until 10 years ago was very, very challenging, but that's all changed. So we have an established London Egg Bank where we can offer donor egg, and we also offer synchronized fresh egg cycles using egg donors. And I'd say our experience is extensive. We've had many, many successful treatment cycles. But what I should do now is focus a little bit more on the London Egg Bank and talk a little bit about their services. But it's equally true of fresh or frozen egg donation. So you can see at the bottom of the panel that over the last 10, 12 years, we have warmed or thawed 16,000 eggs. And out of that 16,000, we have 1,000 successful live births. It's important to remember, because these numbers can be deceptive, is that most patients or couples who are interested in donor egg will purchase anywhere from 6 to perhaps 14 or 15 eggs. So if everybody chose 16 eggs, then we'd have 16,000 successful outcomes or 100% success. But as it is, if the average is 10 eggs thawed per treatment cycle, about 2/3 of couples who do a single cycle will have a successful outcome. So the data is quite gratifying when it comes to success rates with donor egg, be it fresh eggs or frozen eggs from the London Egg Bank. So if we ask the question about what type of patient benefits the most from donor egg, generally it's related to the age of the patient. If you look at the bottom graph on this slide, you can see the chance of a successful live birth in women who are using their own eggs in IVF treatment, which is the green-blue line, versus those patients who use donor egg. So because we're using young donors, typically between the ages of 20 and 33 or 34, you can see that overall the success rates are largely, not completely, but they're largely independent of the age of the recipient. So we have good success rates with donor egg across the entire age group when it comes to donor egg treatment. And of course, the types of patients who might want to look into fertility treatment through the use of donor eggs are, for example, women who have tried with their own eggs and have been successful. There are women who know because of their age, say greater than 45, that their only option is really through the use of donor egg. There are some women who, for various reasons, go into early menopause and therefore have run out of eggs, and so on. So there are numerous indications for the need of donor egg. And we are more than happy to provide that service to a large proportion of patients who are interested in achieving their successful pregnancy through the use of donor egg. So there's an interesting mix of individuals who express interest in fertility treatment through the use of donor egg. But I would say that the majority of patients are typically in their early to mid-late 40s who have tried to conceive through IVF treatment with their own eggs. And as a result of a poor outcome, donor egg has been suggested as perhaps the best option. So fertility treatment through the use of donor egg is actually a relatively straightforward process because in effect with the egg bank, we already have the eggs. So we don't need to stimulate the woman's ovaries as in standard IVF to get the eggs. We already have the eggs available. So therefore it's then a matter of using a sperm source, either donor sperm in some cases for single females or with partner sperm, to create the embryos. And then once you've created the embryos, you can then talk about returning an embryo to the uterus and hopefully, after one or two tries, achieve a successful pregnancy. So from a technical standpoint, egg donation through the service of the London Egg Bank is a relatively straightforward and fairly low stress process compared to the more conventional ways of IVF, which is to stimulate the woman's ovaries over a period of 2 weeks and then retrieve the eggs and then fertilize the eggs and then usually in a separate cycle transfer an embryo or two. One question I often get asked fairly frequently is the concerns about the DNA of the egg donor is not obviously the DNA of the recipient, and therefore one is using donor egg in a recipient who has a different DNA makeup. But at the end of the day, humans their DNA makeup is not fundamentally different. the reason being, of course, is that humans can interbreed. So our DNA is not it is the fundamental background of procreation, but it does not impart a lot of the subtleties that are seen as from the baby in the womb and post delivery, because a lot of that is regulatory stuff that happens during the in utero environment. Plus, the embryo itself has to be programmed so it can implant in the mother's womb. And then once in the mother's womb, the intrauterine environment plays an essential role for what is referred to as epigenetics, which is the next level above the raw DNA. It's a regulatory component that determines the activity of the DNA that's been inherited, be it from the woman's own egg or from a donor egg. So that regulatory component is largely controlled by the mother during pregnancy. And of course, you need a womb for successful development. So one should not underestimate the vast level of regulation and control that happens during pregnancy and the crosstalk between the mother and the fetus via the placenta. So this is an emerging area of research, and it's for those who are interested. It's really named after one of the discoverers of this particular phenomenon, and it's referred to as the Barker, as in Barker, the Barker hypothesis, how the in utero environment has a huge impact on not only the pregnancy but the subsequent development of the new child through adulthood. So this is a very important area of research right now, but it's something that should be taken into account when consider it in weighing up the use of donor egg versus one's own eggs, because the in utero environment is essential for the normal health and development of the growing fetus and should not be underestimated in any way. So let's imagine that you've contacted the egg bank and you've made an appointment because you want to learn more about the services provided through the London Egg Bank. It's a relatively simple stepwise process. Is that first of all, your history would be reviewed by what we broadly refer to as a fertility doctor. And based upon the findings in the history, then the couple or the individual would be assigned a donor egg coordinator to work with them with regard to the services of the egg bank. And as part of that, we also provide counseling. And this all comes as part of an extensive patient support package run by the London Egg Bank. And so these are the crucial steps that any individual or couple would go through if planning treatment through the use of donor egg. But you work with a fertility specialist, you work with a donor egg coordinator, and you can develop a relationship with a fertility counselor as you go through your fertility journey. So this reinforces the relatively simple nature of the donor egg process from a clinical and embryologic standpoint. But this is just one pattern. There are nowadays, because we use fresh eggs and frozen eggs, we use fresh sperm and frozen sperm. There are literally numerous combinations of order in which you could undergo donor egg treatment depending on the wishes of the individual. But an important step is that it's necessary to prime the womb. The lining of the womb, what is referred to as the endometrium, is simply responsive to hormones. And so when we prime the womb lining to try to achieve a pregnancy following embryo transfer, we simply mimic what happens in a natural cycle, which is the lining of the womb is first exposed to estrogen. The role of estrogen is to proliferate the lining and thicken it up. And then this is followed by progesterone, and the role of progesterone is to convert that thickened lining to a receptive phase so that it encourages an embryo to implant. And hopefully, if all goes well, normal development of the placenta and a healthy pregnancy. So that can be synchronized with a fertilization step of the egg so that you create embryos, and at the right time, you can transfer the embryos into that prime lining. So that's one way of approaching donor egg treatment. But it's not the only way, because you can, for example, create the embryos first and then freeze the embryos and then separately prime the womb. And when you know you have embryos to put back, then put an embryo back. And generally, these different options would be discussed with the individual or the couple at the time of their consultation with the fertility specialist. So this summarizes our success rates over the last 8 years or so, including the cumulative pregnancy rates from a cycle of egg donation. And as you can see, and this has been universally seen through numerous studies in different clinics worldwide, that generally the overall success rate is a little bit higher, cumulative pregnancy is a little bit higher when using younger recipients. But above age 40, you see a small drop between 44 and a little bit, very, very small drop, maybe 1% between 41 and 50. This is something that we haven't fully explained yet. In terms of our knowledge, it could be just age itself has a small impact on the ability of an embryo to implant inside the womb. But there is this very small trend, it's about 1% per year for women in their 40s in terms of successful outcome. But if the way to imagine this is that each embryo created from a donor egg has about a 40% chance of resulting in a successful outcome. So if you have 3 embryos available, and it's about 40 to 45% success rate per embryo, and each embryo transfers in the independent event, then the cumulative pregnancy rate, for example, could be as high as 90% from each embryo transfer. How many embryos you have, to some extent, depends on how many eggs you have to begin with. But these are the sorts of numbers that one can expect from a typical cycle of egg donation. So I think for couples who are going through or thinking of going through donor egg, there are a number of advantages or I think positive aspects to the donor egg cycle, because, as I said, the eggs are available. So couples have the luxury of doing due diligence on the egg selection process, talking with the donor egg coordinators and making the decision about how many eggs they might want to use or their expectations with regard to pregnancy. Obviously, we have also young women for various reasons who have very poor eggs themselves, and they might be in their mid-20s. There are some women, for example, who are born without eggs for a genetic reason, and they also might be ultimately interested in having 2 or 3 children. If they want genetic siblings, then of course they would need to start off with more eggs than, say, a couple who are interested in only having one successful outcome. But once you've made the decision, the process can move forward fairly easily and quickly. And of course, because you're using frozen eggs and potentially frozen embryos, you could choose the timing of putting an embryo back. And therefore, knowing that you have embryos in storage, then of course you have the peace of mind that you can choose at some point in the future when you might want to strive to have a successful pregnancy. one of the things to remember about using frozen eggs, it is also true of fresh eggs, it is also true of women using their own eggs in IVF treatment, that at the end of the day, even though the steps are relatively simple, we have relatively little control over the biology. So you can imagine that if you started off with 6 eggs, and these are averages, right, perhaps 5 or 6 of the eggs will survive, perhaps 3 or 4 of the eggs will fertilize normally, and then generally from fertilized eggs to blastocysts, it's about 50%. So you might end up with 1 or 2 blastocysts if you started off with 6 eggs. I've known situations where we started with 6 eggs and we ended up with 5 blastocysts. And equally, we started off with 6 eggs and we've ended up with no blastocysts because until you fertilize the egg, you will never know its viability or its potential. So sometimes we have great excitement, sometimes we have disappointments. But the thing to remember is that the egg bank is aware of these numbers and therefore they have contingencies in terms of a second cycle. If a couple were to fall into that unfortunate group that had no embryos to work with after their first cycle of treatment. So there are compensatory packages that the egg bank will provide couples who have a disappointing outcome. And those sorts of things, you could get more information by talking with one of the donor egg coordinators. It's also important to understand that in the UK, at least, IVF treatment, and it doesn't matter what type of IVF treatment it is highly regulated by the Human Fertilization Embryology Authority. The HFEA was created by an act of parliament, therefore the HFEA is the law. And this dates back, these concepts developed through the parliamentary process was really the result of the first IVF baby in the UK when the process itself raised a lot of moral and ethical issues and religious issues. And all these things were carefully dealt with by serious deliberation. And out of that came the HFEA, whose job is to regulate fertility treatment so that we stick to all the appropriate ethical guidelines and we're not doing anything illegal. So we are highly regulated, and it's also true of donor egg because under the regulations with donor egg, and it's also true of donor sperm, any offspring conceived through donor egg or donor sperm, or both in some cases, the offspring do have the right to get information from the HFEA about the donors and have the right, if they wanted to, if the donors are agreeable, to actually meet with them and get more information about. Typically, they're interested in why individuals became egg donors or sperm donors. They're not looking for replacement parents, far from it. But sometimes donors are curious about the recipients and vice versa. So offspring do have the right to get more information about the donors. And therefore that puts an additional burden on the parents so that they have complete transparency about how children were conceived. So this is an interesting topic of conversation, but we have learned a lot about children conceived through the use of donor sperm, because donor sperm has been around for decades, and therefore there are many adults walking around who were conceived through the use of donor sperm, but large-scale donor egg treatment has only come about as a result of the use of donor egg banks. And so a lot of the offspring are still very, very young and therefore have not reached the age of adulthood at this stage. But this is why we require that couples meet with a fertility counselor, and that we can document that they've been fully informed about the HFVA regulations regarding the use of donor gametes, both eggs and sperm, in the United Kingdom. And this emphasizes once again some of the important things that one can argue with regard to not having strict anonymity when it comes to the use of donor eggs or donor sperm in the UK. It is all about empowerment and transparency in the process. I'm going to spend a little bit of time talking about what egg donors go through, just to show how committed they have to be to become egg donors. But we accept women for egg donation from ages of 18 through 35. We don't select against any ethnicities or racial backgrounds or anything like that, because we cater to all groups. We do testing of ovarian health. We do an extensive family history for evidence of genetic problems. And we have to do extensive infectious disease screening of all egg donors. I should say that as a group, the clinicians meet once a week to review the majority of cases that raise any particular issues, be it a medical issue or a genetic issue, before they're ever approved for egg donation. And of course, they have to also then to meet the regulatory requirements, the HFEA requirements for egg donation. And you can see that the majority of egg donors, majority are graduates. A significant number have gone to A-level GCSEs, and then of course we also have postgraduate individuals who also want to be egg donors. But the majority of the donors have graduated from college. And this gives a background on some of the motivations of egg donors. So the majority look upon this. I look upon it as sort of form of sisterhood, where there are women who have eggs and there are some women who don't have eggs. And no woman could ever use all her own eggs. There are just too many of them. And so quite a few of these women are willing to go through a cycle of ovarian stimulation and egg retrieval to provide eggs for the egg bank. And we have some patients who might donate 3 or 4 times, depending on their own experiences with going through the process. But it's a wide selection of motivations, but the bulk are generally young women who know that they have a lot of eggs to spare and would like to donate them to women who, unfortunately, for various reasons, do not have eggs that are viable. And we also encourage egg donors to write little notes about what motivates them to be egg donors. And as I say, that some do it because they knew of a family member who needed IVF treatment, and therefore want to help women in that way. And as I say, that some women, they know about how the ovaries work in ovarian physiology, and they know that there's a ton of eggs available in the ovaries, and they don't mind if a few are extracted to provide eggs for women who don't have eggs. This is a broader look at what the testing that we do in the history that we obtain from all prospective egg donors in terms of history, genetics, screening. the London Egg Bank has various levels of data that they can provide depending on the commitment of the individual. So we have a small amount of information for people who are just interested in browsing through the egg bank to see what sort of donors, the types of donors available, maybe their ethnicity, and so on. If a couple or individual then makes a commitment to doing egg donation treatment, then we can increase the amount of information that's available, as shown here in terms of the blood type, what their screening, whether or not they carry a genetic condition. I think it's important to remember that we all carry genetic conditions, but we don't have genetic diseases, because you need, for most conditions, genetic conditions, you need 240 genes, one on each of each chromosome, to have a genetic disease. But we all carry a single mutation for a particular disease, but not two mutations of that disease. So we treat those donors the same as we would treat donors who carried no mutations. But it's important to understand that every human being carries mutations of single mutations of every gene. The average is that there are at least 4 mutations in the genes, human genes, that an individual carries. They're not aware of it because they don't have the disease, but they do carry mutations within individual genes. We do genetic screening if on some of the more common genes worldwide, and then if there is a specific family history, we might then do additional testing of selected genes beforehand. But this is the type of information that couples or individuals would look at if they've made a commitment to proceed with a treatment through the use of donor egg. This shows some of the packages that the egg bank has to offer. I'm going to hand you back to someone who knows far more than I do about the pricing and services of the egg bank. So I'll hand back to Shifa just to go through the last few slides.
Thank you, Dr. Summers. So at the London Egg Bank, we have different treatment packages because we understand that different patients may have different needs and expectations from their treatment. So we do single cycle packages, which is IVF with 6 frozen eggs or IVF with 10 frozen eggs. There is a minimum of 6 that you need to purchase from frozen eggs, but there is no maximum. So you can also purchase eggs from 2 different donors in one cycle. But the single cycle packages, basically you pay for the eggs first and then you pay for the treatment cost. The treatment cost will include the cost of creating embryos using ICSI and also 1 embryo transfer and the scans that you will do with us during the treatment. So the the package with 6 eggs is £12,750. The package with 10 eggs is £16,200. We also do some 2 cycle packages. These are our refund packages, which start from £22,000. They are of 2 types. One is silver cycle package and the other one is gold package. For these packages, we give you a refund if you don't have a baby. However, there is an eligibility criteria for this package. So if you're interested and if you're having a doctor's consultation with us, please mention to your doctor so that they can discuss your eligibility for you. The basic criteria in this is that the sperm has to be of within the normal parameters, and also that the woman carrying the pregnancy has to be under the age of 50. For these 2 packages, the silver package gives you a 50% refund if you don't have a baby, which is for £22,000, and the gold package, which is for £30,000, gives you a refund of 100% if you don't have a baby. And for both of these packages, you will have access to a curated list of donors from whom we've seen outcomes and we have used their eggs in our clinic before. Next slide, please, Dr. Summers. Okay, this is just talking about the 2-cycle package. The one package that I forgot to mention is a standard 2-cycle package. So in case you are not eligible for a silver or gold package, but you would like to pay for multiple embryo transfers in one go, then you can also go for a standard 2-cycle package from in which you can have any fresh or frozen donor either from our catalog or with the help of our matching team, you can get a fresh donor and you can have up to 2 donor egg allocations. This package ends with a 20-week pregnancy. Next slide, please. Your next steps. So as Dr. Summers already mentioned that to start your journey with us, you would need to book in an initial consultation with one of our fertility specialists. And following that, you'll have a call with one of the matching coordinators who would be able to discuss with you both fresh and frozen according to your doctor's advice and your preference. We will take your donor characteristic preferences and would try to look into a database to find some potential matches and suggest that for you. For the initial consultation, we do require a scan report from within 6 months, an ultrasound pelvic scan report, and a semen analysis from within 12 months. If you already have these reports, have done that elsewhere, that's absolutely fine. You can send them over to us. We can confirm if you're able to accept them, and we would then be able to book a doctor's consultation for you. Following your doctor's consultation, you'll have a counseling session with one of our counselors to discuss the implications of using donor eggs or any support that you may need. After which you are ready to begin treatment once you have completed your screening test, completed your checklist, and purchased your donor eggs. Next slide, please. And as a thank you for attending today, we are offering reduced fee initial consultation packages, the details of which are on the slide. You'll also receive an email tomorrow with this offer. And if you would like to proceed and book doctor's consultation or any investigation appointments with us, or if you have any other questions or would like to speak to a member of our team, please respond to the email and we'd be happy to assist you. And that brings us to the end of our presentation today, and we'll now be moving on to our Q&A sessions. Thank you everyone for putting down your questions. The first question is, I have spoken to a clinic in Spain and they recommended that I go on the pill in advance for this type of IVF due to my very inconsistent cycles. Would that be standard process here as well?
No, it a lot depends on the cycle. If the recipient is having regular cycles, if the recipient is having regular menstrual cycles, we would not intervene with birth control pills or any other form of hormonal manipulation. We would just wait for the patient to get their period, and then we would start the treatment to prime the womb to put back an embryo. For women who are menopausal, I typically will put them through a mock cycle, which consists of natural estrogen and natural progesterone. I don't use synthetic hormones such as a birth control pill. I like to do a priming of the womb with estrogen and progesterone in what is called a mock cycle, so I can actually learn a little bit about how the womb is responding to the hormones that eventually we're going to have to give to prime the womb to put an embryo back. But in general, I avoid the use of oral contraceptive pills in women, particularly in women in their mid-late 40s, because oral contraceptive pills are contraindicated. So a lot depends on the situation, but I'm generally loath to use oral contraceptive pills when dealing with donor egg recipient patients.
Thank you, Dr. Summers. The next question is regarding matching. The question is, how closely can we match to a donor to look like the mother? So in terms of matching, as I mentioned before, we can take your preferences. So, for example, hair color, eye color, ethnicity, etc. If you are looking at frozen egg bank, you can go to our website and you'll already be able to see what characteristics information we are able to share. But we unfortunately cannot guarantee that the baby will be born with the same characteristics, as there's an effect of genetics as well, and two sisters can look different. Dr. Summers, would you like to add any clinical information to that in terms of matching?
No, I mean, as I mentioned during my review, you know, at the naked DNA level, we're not really not that different. I mean, I can tell you from personal experience, I've had couples, for example, who have used donor sperm uh, because the male partner, for various reasons, had no sperm. He was azoospermic. So they can do relatively simple fertility treatment, which is you just inseminate with donor sperm at the right time of the cycle. But they always come back later on, and you see them interacting. You would never know that they had used any form of donor gamete based upon their behavior towards their child. But oftentimes also the nurses will come by and go things like, "Oh, look, he looks just like dad," and it's like, well, it's donor sperm. So I think that it's it's biology. We all have a lot of the same basic features. We've got two eyes, a nose, two nostrils, a couple of eyeballs, and so on. So I don't think that unless there's a strong preference for maybe a particular ethnic group, I think that most people have pretty similar features when it comes to adult appearances. So I don't have any strong feelings about the selection process. I think that the key is for when it's donor egg uh, selection. I think it's important for the individual or the couple to do due diligence on the process. I think it's important that they ask directed questions of the donor egg coordinator. It's essential that they be fully informed about the process so that they can reach a stage where they're very comfortable making an informed decision. And I think that's the main part of going through the donor egg selection process. And appearances, yeah, I mean, you can go to the US, for example, and there are clinics over there who do highly detailed facial matching of what the mother looked like when she was a child and what the donor looked like when she was a child, and so on and so forth. But I think in general, Mother Nature overall did a pretty good job when it comes to procreation, and I have faith in that process as a clinician. So, but the key is to be fully satisfied with the journey when you make the informed decision about which donor you want, and you've really tested the donor egg coordinators in getting the information that will make you in a position to make a comfortable decision about your donor.
Thank you, Dr. Summers. The next question is, what percentage of pregnancies get to full term?
If you have a healthy recipient with no underlying comorbidities or medical issues, then the risk of a miscarriage, once you have a pregnancy, the risk of a miscarriage or loss, because most miscarriages occur in the first trimester, uh, the risk of a loss is really determined by the age of the egg donor, not by the age of the recipient. So if you look at say, women in their mid-20s who conceive naturally, like their miscarriage risk is about 10%. So if you're using an egg donor uh, and who's in their mid-20s and the recipient is fully healthy, that would be the miscarriage risk, roughly. Um, you do see, not because of egg donation, but because of IVF treatment, you do see a slightly higher risk of stillbirth in women who conceive through ART. Doesn't matter what type of ART it is, or assisted reproductive technologies, which is, basically it's IVF, but there are obviously variations of IVF. There's obviously donor egg IVF. But if you look at ART outcomes, you'll see a slightly higher risk of stillbirth in women who have conceived through the use of ART. And that's why, for example, nowadays, the most women who are pregnant through IVF treatment are typically not allowed to go past 40 weeks of pregnancy to reduce that small risk. It's a small increase on an already low risk, but it's a real difference between ART pregnancies and natural conceptions. But we're dealing about small numbers here, so it's a small increase on already a small number, but it's definitely a little bit higher when it comes to ART. So there are that's close to full term. But most other pregnancies occur in the first trimester, and they're usually determined by the age of the woman, or in this case, the age of the egg donor, not the age of the recipient. As I said, as long as there are no other complicated medical issues or comorbidities in the such as diabetes or high blood pressure or kidney disease, all those things would add a risk to the pregnancy. I usually, for example, in women who are over the age of 40 who are interested in egg donation, I will normally, if they have comorbidities, I would normally arrange for them to have a consultation with a maternal fetal medicine consultant so that they can be fully informed of what the additional risks might be in the event of pregnancy. I say it's not because you're doing donor egg. It's not because you're doing IVF. It's because over the age of 40, there are additional risks from pregnancy. So even women who conceive naturally in their early 40s are still considered a high-risk pregnancy and will be monitored and followed a little bit differently than, say, a 30-year-old who gets pregnant naturally. So for couples to be fully informed, if there are comorbidities in the female who's planning for pregnancy, I will normally arrange to meet with a consultant in maternal fetal medicine to learn more about how they will be monitored during the pregnancy.
Perfect. Thank you, Dr. Summers. That was very informative. The next question is there a wait for availability of eggs? I can take this one. So there is no waiting times for using eggs from our bank. If you are looking at frozen eggs, the donors that you see on the website, they have completed the process of their donation. So we have their eggs in storage already. So they're ready to be thawed, ready to be used in treatment. So there is absolutely no waiting times for frozen eggs. For fresh eggs, depending on your preferences of what kind of a donor you're looking for, we can help you find a donor very quickly. I would say the average wait time with fresh is about 2 to 3 months. For example, if you're looking for an ethnic minority donor, then it may take longer, but it won't take around like 2 years because we do egg collections, 40 to 50 egg collections in a month at our clinic. So we are very fortunate to have a good number of donors. So we'll be able to help and find you a good donor pretty quickly. The next question is, how do you know the good quality embryos? Until what day does the embryo culture, 3 or 5?
Okay. So let's go back a little bit more and consider what the egg bank actually stores. Right. So the egg bank stores eggs, as the name suggests, but they store a particular type of egg which has gone through a maturation process and is referred to as an M2 oocyte. It sounds a fancy term, but it's a certain morphologic maturation stage of the egg. The reason that M2 oocytes are important is that when a woman has natural cycles and ovulates a single egg, she releases in that ovulation an M2 oocyte. And the reason that's important is that it's the only stage of oocyte maturation that is receptive to fertilization by sperm. So the egg bank, in essence, stores thousands of M2 oocytes. So when a woman undergoes an egg retrieval, a donor undergoes an egg retrieval, the lab searches through the eggs that are retrieved and puts aside and freezes all the M2 oocytes. So under the microscope, they all look the same. They're all M2 oocytes. But as I alluded to earlier, the potential of that egg, you will not know until it's fertilized. So you need to get to day 3, which is an 8-cell stage, to have good embryo development. And if we have embryos that make it to day 3, then we allow them to grow to day 5 or 6 at the blastocyst stage. And at the blastocyst stage, it's those embryos are then graded, a series of A's and B's and C's. And so we can rank the quality of the blastocyst by its A, B, C, D grading. So when a patient undergoes an embryo transfer, typically the lab will choose the highest grade embryo for the first cycle for transfer, and then they will step down by the ranking if the patients come back for a second cycle or even a third cycle. I have quite a few patients now who are coming back because they have blastocysts in the freezer. They've already had a successful donor egg cycle, and now they're coming back for a second cycle. And so that's always gratifying when you get a decent number of blastocysts. But the plan is to freeze at the blastocyst stage because the survival at the blastocyst stage is much higher than the survival at day 3.
Great. Thank you, Dr. Summers. The next question is, does blood type matter? Are there any rules around blood type matching of donor and recipients and also father?
The answer is no. The only thing that we screen for is what is called RH factor, because that can then have consequences during pregnancy. But if you imagine that there are thousands of couples out there where they all have different blood groups and they're still doing very well with procreation. So there are no restrictions on the blood groups for selecting a donor with a particular recipient. The only issue is RH factor, but that, once again, that does not become an issue until pregnancy. And if there's an RH incompatibility, which happens all the time, even with couples out there, they don't realize that one person is RH positive, the other person is RH negative. But if that happens, then all you have to do in the event of pregnancy is to give RH factor at 28 weeks of pregnancy and also at the time of delivery. And then there's no risk at all. So there really are no significant restrictions on blood grouping when it comes to donor egg or donor sperm treatment.
Thanks. The next question is, are there any lifestyle changes, diet, supplements, etc., you would recommend to increase the chances of successful implantation?
I think that my philosophy is that life should be approached in moderation. Uh, I think it's all about a healthy, balanced diet, staying fairly healthy by going for nice walks, and the use of prenatal vitamins, depending on which side of the Atlantic you happen to live on. But I think I think it really is about common sense stuff. And I think it's a healthy lifestyle, balanced lifestyle, vitamins and fruit and vegetables, and in moderation, and things like that. I don't have any strong feelings about anything else in terms of how one should behave. Obviously, don't smoke, don't drink to excess. I mean, common sense things. But I have no fixed recipe that I force upon patients. I just talk about life in moderation.
Thank you, Dr. Summers. The next question is, can you have two embryos implanted at once to increase the likelihood of conception?
It's an interesting question, and intuitively, you might expect that if you put two embryos back, you would have a higher chance of pregnancy. Um, all the evidence points to the fact that that's not true. So if you had a couple that had two embryos available, in one group put back two embryos at one time, in the other group put back one, and then if it didn't work, put back the second one, the cumulative pregnancy rates by putting back one embryo at a time is actually higher than putting back two at the same time. So the only risk you run by putting back two at the same time is a twin pregnancy. Right. And as I've already mentioned, that for women over the age of 40, a singleton pregnancy is considered a high risk pregnancy. And so if you have twins, you don't double your risk. You sort of quadruple your risk if you have twins and you're over the age of 40 in terms of potential complications. So our policy is that if we have top quality embryos, we would only put back one embryo, because the pregnancy rates are highly acceptable with one embryo. But if you put back two, I say you don't really increase your chance of pregnancy. What you do is you simply increase the twin rate. So in women who have a receptive womb, because maybe the womb is not receptive every month, right? Maybe sometimes it's not quite right, sometimes it is right. But if you put back two in the month that it's not quite right, well, you can put back 8 embryos and it's not going to work, right? But if you put back one at a time, you've got a greater chance of getting an optimal lining. And I think that's the reason why putting back one at a time cumulatively will give a higher pregnancy rate by putting back two at the same time. So the only risk is twins. And we are under immense pressure from the HFEA not to put back two embryos. So in their guidelines, it's not law, but in their guidelines, that they don't look kindly on twin pregnancies because of the associated risk, and that's magnified a bit if you're dealing with donor egg cycles and where the recipient is over the age of 40. So there are times when I have put back two, but the patients have been extensively counseled. And the other reason is that they've got two embryos left in the freezer, but they're both lower quality. So the probability of one resulting in pregnancy is going to be lower than if you've got a top quality embryo. So the likelihood that if you put back two poor quality embryos that both would result in pregnancy is going to be lower. And therefore, you might improve the chance of at least one resulting in a pregnancy. So I have done under those circumstances, I've put back two embryos, but the patients have still been extensively counseled on the risk of twins, and have a full understanding, and we document they have a full understanding of what the risks are. in the event of a twin pregnancy. But most of the time, we have fairly decent embryos to put back. And so the question of putting back two embryos, in my experience, does not come up very often.
Perfect. Thank you, Dr. Summers. The next question is, do you support surrogacy using donor eggs? Do you have a price list on your website? So the answer to this is yes, we do support surrogacy. We have a huge number of patients coming through for surrogacy and using donor eggs. Some of them create embryos with us, and if their surrogate is at a different location, they would transport the embryos to be used, or they would have the entire treatment with us. So we do support surrogacy. Unfortunately, the price list is not on our website yet. We are working on putting them up on the website. But when we send you an email tomorrow, please do reply to that email and we will be able to send you the price list in an email. The next question is there are some questions about our clinic locations. So you can have treatment at any of our clinic. We have a clinic in Darlington, Cardiff, and London. We also have one in Bromley, and then we have certain satellite clinics around these clinic locations where you can attend for more scan and blood appointments. But the real treatment, which is embryo transfer or the embryo creation, needs to take place at either London, Cardiff, or Darlington. The packages would differ if you were going to any other location than London, because our 2-cycle packages are only available if you are having treatment in London. Also, if you are an international patient or you live far away from London, you can always do scans or your bloods or any appointments locally and send us the reports, and we'd be happy to get it reviewed by your doctor and advise you on medication and next steps. Also, we can arrange the doctor's consultation online, the nurse consultation online as well. So if you were just doing the treatment with us, then I would say you would require about 2 to 3 appointments in person. Rest of them can always be done locally or online. Dr. Summers, there are some questions about PGTA. The first question is if we offer PGTA, and the second one is if it would increase the chances of success.
Yeah, we have patients who request PGTA with donor egg. They are counseled extensively because I think overall the benefits of PGTA with egg donors is marginal. If you look at the data on women under the age of 35, for example, who do PGTA with their own eggs, in women who under the age of 35 don't do PGTA but put an embryo back, you don't see a significant difference in pregnancy rate. That's not to say that there aren't special circumstances where we might do PGTA. For example, if the male partner had what is called a balanced chromosomal translocation, and therefore the couple was at increased risk of miscarriage, even if they're doing donor egg, then that would be a reason for offering PGTA. There are patients who, for various reasons, want to, as best as possible, decrease the risk of having a miscarriage, and therefore might go for PGTA. But if you look at the data on miscarriage rates following PGTA, they are still about 10 to 12%, which is similar to what you'd expect if your egg donor was, say, 24 years old. I think that there might be an indication if the egg donor is perhaps 33 or 34 as opposed to 25. But I think for me, that would represent focusing on individualized care and having a really good understanding of the motivations behind wanting PGTA when using an egg donor. But yes, it is offered, and there are patients who have it done. But I would really have a very detailed discussion and try to understand, for me, my perspective, the motivations for wanting to spend the extra money on PGTA when the benefits might be marginal. So,
Perfect. Thank you, Dr. Summers. We're going to take one last question, because this is something that has been asked quite a few times. If I have endometriosis, do I need any additional test when using donor eggs?
yeah, endometriosis from a fertility standpoint is always a challenge. There is some evidence that endometriosis can change the receptivity of the lining of the womb. Um, what I normally try to do, and it's practice I've been doing for many years, is I try to, depending on the stage of the endometriosis, is it stage 1 or is it stage 4, for example? Is it extensive or not? Uh, I think for me, what I typically do is I try to, because endometriosis is an inflammatory condition, I try to suppress the endometriosis for 4 to 6 weeks by downregulating the ovaries and reducing the estrogen level to undetectable, because that's what feeds the endometriosis. So I try to downregulate the ovaries for a period of time to atrophy the endometriosis, and then as quickly as possible, try to prime the womb lining to develop normally before the endometriosis has a chance to wake up again. So that's the approach I use for women who have a history of endometriosis. But let's say it's really stage 3, stage 4 endometriosis when I do that sort of thing. Stage 1, if it's minimal endometriosis, generally for that it's better just to have it treated by laparoscopy, and then do the treatment. But once again, it comes down to focusing on individualized care depending on the circumstances. So.
Thank you, Dr. Summers. And that brings us to the end of our session today. Thank you so much, everyone, for joining us. And apologies we weren't able to cover all questions, but please feel free to respond to our email tomorrow and we'll be able to answer your questions and get back to you. And we hope you found this webinar helpful and informative, and that it's given you a clear understanding of IVF treatments that using donor eggs. And a very special thank you to Dr. Summers for sharing his time, expertise, and valuable insight with us this evening. If you have any other further questions or would like to speak to with our team directly, please don't hesitate to get in touch with us. As I mentioned, you'll receive a follow-up email tomorrow with more information and contact details. And on behalf of everyone here at London Egg Bank, thank you once again. And we wish you all very best for your fertility journey and have a lovely evening.